Good morning, good afternoon, ladies and gentlemen. My name is Philip Bell. I'm the Chief Commercial Officer of iThera Medical, and I would like to welcome you to this exclusive webcast on multispectral optoacoustic tomography. We will have about 30 to 45 minutes of presentation and then open it up for questions. You can type your questions at any time in the questions box on the webinar status bar, and we will try to cover as many of them as we can during the Q&A at the end. In addition, this presentation will be recorded, and you will all receive a link to the recording in a follow-up email in the coming days. And now, let me hand over to my colleague Wouter Driessen, who will lead you through the presentation.
Thank you, Philip, and thank you, attendees, for joining us this morning in Munich. Today I'll be presenting on a relatively new biomedical imaging modality. We call it Multispectral Optoacoustic Tomography. I'll refer to that as MSOT in the presentation. Today I'll show some applications on how we can use MSOT imaging for in vivo biodistribution and pharmacokinetic imaging applications. When we look at the preclinical imaging role in the drug discovery process, we can see several stages to where imaging can be very important. First of all, if we look at the entire drug development process, it takes up to 12 years, and it exists of a discovery stage early on and a clinical stage later on. First of all, in this webinar, we want to focus on the discovery stage because it's very important to make the right decisions early on, because the clinical stage gets very expensive and very time-consuming. So if good decisions can be made early on in the discovery process, this would be very beneficial to patients and also companies itself. So in the discovery stage, there's various processes where molecular imaging or imaging in general can play a big role, and some of it we will highlight today. In the discovery stage, targets will be validated and identified, and the molecular imaging process can play a huge role in this, in localizing and validating the expression levels of certain receptors. In addition, imaging can show drug localization and efficacy by characterizing disease pathology or response to treatment. However, that would be a topic of a different webinar. Today we want to focus on how we can use imaging to deduce pharmacokinetic and biodistribution information. This would be in the hit expansion or lead to candidate phase of the discovery phase in the drug development process, and we can use this type of imaging to identify potential pharmacokinetic issues that may exist with the hits or the leads. And we can optimize animal pharmacokinetic profiles. So I'll show some examples on how we can use MSOT imaging specifically to look at PK profiles non-invasively. Secondly, we can also establish pharmacokinetic, pharmacodynamic relationships in preclinical studies, and that this will be very important to get an idea of the time and the efficacy of the drug that you're trying to develop. I'll show quite a few examples on ADME analysis. So this stands for absorption, distribution, metabolism, and excretion, and characterization of these processes is very important in the drug development process. And lastly, and also very important aspect, is that MSOT imaging provides the opportunity to do a toxicity screening of your hits and leads. So we can screen certain compounds for toxicity, for example, renal toxicity, and I'll show a specific example of that. And we can look at the toxicokinetics by doing MSOT imaging. A short introduction on MSOT itself, because it's a relatively new biomedical imaging modality, so we should introduce it here. What we do is we image by using the photoacoustic effect. That means we use near-infrared light and detect ultrasound waves. In our case, we use near-infrared laser light delivered by a laser that operates between 680 and 980 nanometers. The MS in MSOT stands for multispectral, and that means that we typically use at least 5 wavelengths, 5 different wavelengths, indicated by the 5 arrows of different color here. We illuminate the object, a molecule in this cartoon, but more typically a whole mouse, and that light gets absorbed, and this leads to a thermoelastic expansion after absorption. This thermoelastic expansion leads to ultrasound waves, and this is what we detect tomographically. So So that's the T in MSOT stands for tomography, and that means that we detect those photoacoustic signals surrounding the animal in a tomographic way. We can then reconstruct these images, and we get whole cross-sectional images of the mouse. In this example here, we show a subcutaneous tumor on the back of the mouse, and each individual wavelength that we illuminate with leads to one image. We can then use spectral decomposition techniques with certain algorithms to unmix specific signals very sensitively. In this example here, in green, we show the ICG signal overlaid on a grayscale single wavelength image, and we can see very sensitively and specifically where this ICG is located throughout the whole mouse. The user benefits of using MSOT versus PET or optical images is that we have that we can achieve a great resolution even at depth. So we achieve 150 micrometer resolution at depth throughout the entire cross-section of the mouse, which is 10 to 100-fold better compared to PET or optical systems at depth, where we have to measure the resolution on the millimeter scale rather than the micrometer scale. If we have molecular imaging agents, we can achieve molecular specificity, and because of the speed of the imaging technique, we can do this in real time. The laser operates at 10 Hertz, so we can look at 10 individual wavelengths per second. So if we use 5 different wavelengths, we have a multispectral image every half second. So this is close to real time. And lastly, the technique is very safe and cost efficient. We don't need any special infrastructure, and there is no ionizing radiation or radioactivity. The MSOT system that we'll be talking about today is mostly based on the Envision, shown here on the left, and these systems are specifically designed for optimal optoacoustic performance. Two very important design characteristics of the equipment is first of all the tomographic ultrasound detection. Our ultrasound arrays are designed to be tomographic, and this is designed to achieve whole body imaging. So we can image the mouse from head to tail and get whole body cross-sectional images at high resolution because of the design of the tomographic ultrasound detectors. Second of all, we have a very fast tuning laser specifically designed for us, so we can choose any wavelength between 680 and 980 nanometers. And because of the fast tuning, we can look at 10 individual wavelengths per second, so we don't have any loss in tuning time. And this allows us to do very fast, real-time multispectral imaging, which is very important for the applications that I'll be discussing today. In the middle here, I show an experimental imaging platform, which is a new piece of equipment that we are starting to market now, and this is based on handheld ultrasound probes. These are also tomographic ultrasound probes, but these can be used to scan larger animals or even humans ultimately. So we're very interested in translating this technology to the clinic, so we are working on systems like the EIP shown in the middle. But today's presentation will be focused on the Envision system and how we can use this for pharmacokinetic and biodistribution imaging. This is a little cartoon about how an MSOT experiment would look like. The system is a standalone system. The anesthesia would be connected in the bottom. And if I hit play here, we can see the mouse positioned in a specifically designed animal holder. The mouse is placed in the imaging chamber, and we can see the ultrasound transducer here in black. We move the mouse to the desired position. We illuminate all around the animal. This leads to the ultrasound waves, which we detect tomographically, and we then move the mouse forward to image the next body position. Those different cross-sectional images can then be stitched together in three-dimensional volumes. What can we detect by MSOT? As I said, the laser operates between 680 and 980 nanometers, so the probe that you want to detect must have a characteristic absorbance in that region. First of all, that allows us to look at endogenous absorbers. So we can look at hemoglobin, and we can distinguish oxygenated from deoxygenated hemoglobin, so we can actually look at oxygenation status of, for example, tumors. We can also look at melanin, so if there is melanin in the mouse or in the tumor tissue, which is often the case for melanoma, we can actually detect this without having to use any contrast agents. However, today we'll see mostly examples of exogenous probes that we've used in MSOT, and there's a whole library of available compounds available. First of all, we can look at fluorescent dyes and chromophores. very importantly, ICG, which is an FDA-approved fluorophore, can be used and detected very well by MSOT. And another dye that can be used is methylene blue, which is also often already used in the clinic. So these are dyes that are readily available and can be detected by MSOT. We can also look at nanoparticles, for example, gold nanorods that can be fully tuned to be absorbing in the 680 to 980 nanometer range. Basically, if you make the nanorods longer, they will absorb at higher wavelengths, and this can be fully tuned. And lastly, there's certain genetic reporters available. For example, fluorescent proteins are being evolved to absorb more and more into the near-infrared region, and the highest near-infrared proteins available absorb now at 710 nanometers. We can also look at chromogenic proteins. Often these are bacterial proteins that are colorful, and these can also be detected by MSOT. So what type of information do we acquire? So first of all, based on the optical absorption of tissue, we actually can achieve anatomical information. So just based on hemoglobin and melanin absorption, we can see cross-sectional images of a mouse and different organs. Because we can distinguish the different types of hemoglobin, and we can see oxygenated versus deoxygenated hemoglobin, we can actually do functional imaging. If we use a perfusion agent such as ICG, we can also do perfusion imaging, and I'll show examples of these later on into the presentation. But first of all, let's look at a few examples of this anatomical and functional imaging. On this slide, on the top in the grayscale images, I show typical cross-sectional images that you would achieve once you turn on the laser in the Envision system. In the bottom row, we have RGB images of post-mortem of a mouse that we've cryosliced for reference anatomy. So if you look at the brain, we can image this with an intact skin and skull, so we don't have to place any cranial windows, and we can image through the intact skin and skull, and we see the vascular structures in the brain. For example, labeled in C, we can see the temporal artery at the side of the head. We can also see the superior sagittal sinus and the ventricles, just based on the hemoglobin contrast. Moving down in the animal, we can see the liver, labeled with A, we see the spinal cord, B, the vena cava, C, and throughout most of the image we can see the liver and the microvessels in the liver. D, the black area, is the stomach, and E would be the aorta. Moving down even further, we're now in the kidney and spleen area. The spleen is labeled by E, and labeled by B, we can see the kidney, and we can actually distinguish the renal cortex from the renal pelvis. And this is important for one of the applications that we'll be discussing today. We'll have a more detailed look at that later. On the right, I show the functional imaging based on deoxyhemoglobin imaging. On the top, we see a tumor, a three-dimensional tumor, where in red, we see the oxygenated hemoglobin, in blue, the deoxygenated hemoglobin, and we can identify hypoxic areas within the tumor. On the bottom, we see the hind limbs of a mouse, so we can look at the legs and the oxygenation status in the hind limbs of these mice without using any contrast. Now, if we do use contrast agents, we can actually achieve molecular information, for example, by using targeted probes or fluorescent proteins. And lastly, and the topic of most of this presentation, we can get kinetic information. We can look at the pharmacokinetics of dyes, and we can look at biodistribution analysis in high detail. In this presentation, I split up the topics in 4 general topics: PK, so pharmacokinetics; ADME, which stands for absorption, distribution, metabolism, and excretion; TOX for toxicity; and DCE, dynamic contrast enhanced MSOT. So we'll have a look how we can use MSOT imaging to determine plasma pharmacokinetics. We'll have a look at the absorption process after all administration of compounds, and we'll look at the distribution and metabolism of various compounds, nanoparticles, and small molecular weight compounds. And we'll look at the different excretion pathways of some exogenous compounds. We'll have a look at how we can use MSOT to assess renal toxicity, and I'll finish off with a new technique that we call dynamic contrast enhanced MSOT that gives you new, unique information about perfusion status of tumors, for example. So in this first PK example I show here, on the top panel, I show images of a pharmacokinetic process. Basically, we injected a cyanide-based molecular imaging agent that is specific for macrophages, but in this case, we're looking at the pharmacokinetic properties of this dye. We injected this dye systemically, and right after imaging, we see a very large signal in the jugular veins of these mice, shown here in the bottom of the image. Over time, the signal gradually decreases over the course of about 30 minutes, and if we then draw a region of interest over the jugular vein, we can actually quantify these values and relate this to concentrations in the bloodstream. So the graph on the bottom left shows in blue circles MSOT-derived data points of that probe concentration over time. The green line is now a pharmacokinetic model line. So we did some pharmacokinetic modeling, and actually were able to derive important pharmacokinetic parameters, for example, the half-life. So we were able to determine non-invasively that the half-life of this probe is about 20 minutes. If you want to learn more about this probe and also some of the experiments, you can read this in the Chemical Communications paper that came out a few weeks ago, which basically describes some of these experiments in the probe in more detail. The second example is a very similar experiment where we again image the jugular vein area of the mouse, but in this case we injected different formulations of ICG. On the graph on the right in pink, we see regular ICG, which is relatively fast clearing. It only has a half-life of about 3 to 4 minutes in the mouse bloodstream, so it clears pretty rapidly. But once we put ICG in liposomal formulations, the half-life actually gets extended. So we made 3 different formulations. We made positively charged liposomes, negatively charged liposomes, and lastly we made pegylated negatively charged liposomes. So especially if you look at the pegylated liposomes in blue, we can see that we extend the half-life because the liposomes now escape the uptake by the macrophage, so they circulate much longer, and we can achieve relatively stable ICG levels over the course of hours using these techniques. And these differences can be non-invasively detected by MSOT imaging. Moving on to absorption, distribution, metabolism, and excretion imaging, we start with having a look at the absorption process. So in this case, we took again ICG, only 10 nanomoles, and placed this by oral gavage into the stomach of mice, and then imaged these mice over time. In the top panel here, we can see the stomach signal at 5-minute time points, and as we go over time, this is for 2 hours total, we see the signal decreasing in the stomach, and actually we see a signal pickup in the liver, the other areas of the mouse. So basically what we can image here is gastric emptying occurring over the course of 2 hours. The ICG will then end up in the intestines, after which it can be absorbed, and this will lead to uptake into the liver. So we see gastric emptying, we can see the ICG being absorbed and ending up in the liver. We can quantify these processes, what I show on the bottom right. These blue circles again are MSOT-derived data points of signal over time, with the line being the pharmacokinetically modeled fit. So we can derive the elimination half-life of ICG from the stomach to be about 36 minutes, and we can see that the ICG ends up in the liver after it's being absorbed. So this is in 2-dimensional way. We can do the same experiment in 3 dimensions, which I show here. So now in the circle on top we see the stomach, and right next to the stomach we can see the liver. So if we observe the stomach area, we can see this decrease of ICG signal over time again, this time over 80 minutes. And as the stomach is emptying, we can see the signal pick up in the intestines and also in liver over time. This video here shows it as well. So in the beginning there's a lot of signal in the stomach area, which gradually decreases due to the gastric emptying. We can see the excretion in the intestines, but we can also see the absorption and the subsequent uptake in the liver of this ICG compound. Here we have an example of a whole body distribution of a molecular imaging probe. This was a collaboration with Dr. Elena Dubitskovskaya from EPFL in Switzerland, and she has a probe that's basically a fatty acid conjugated to ICG. So this ICG-labeled fatty acid gets taken up with metabolically active organs, and it also gets cleared, of course, after injection. So what I show here is whole body scans, whole body MSOT scans of a mouse. On the left, we see a single wavelength image of a mouse from head to the base of the tail. So on the top, we can see the eyes and the superior sagittal sinus, and on the bottom, we have the base of the tail. So these scans basically from head to tail take about 10 minutes. So in 10 minutes, we can get a very detailed overview of whole body biodistribution of this probe. If you look at the fatty acid distribution profile, we can see that some of the signal is occurring in the brown adipose tissue, labeled with BAT, which was shown before with optical imaging methods that this probe gets taken up in these areas. But we can also see the clearance process. So we see the probe located in the liver, labeled with L. We can see it in the spleen, labeled with S, and it starts to show up in the intestines, labeled with I. So in just 10 minutes, we can get a whole body view of the distribution of this probe. And we can also have a look at higher resolution cross-sectional images shown here. So we can get a very nice three-dimensional idea of where the probe is located. And on the right, we see the validation of these findings by cryofluorescence. So this is on a whole body level. We can also do this with a higher temporal resolution on single cross-sectional images, which is what I show here. Here we have, again, that specific probe that I showed earlier that is specific for macrophages. Earlier I showed the blood pharmacokinetics. Now I show the organ biodistribution pharmacokinetics. So we can look at individual cross-sectional areas. We can image the liver, kidney, and spleen, and we can get an idea of how this probe is being taken up by the metabolizing organs or is being cleared by the clearing organs. So by imaging single cross-sections, we can get a very high temporal resolution, and we can figure out how fast the probe is entering what organs and how fast it's leaving those organs again. So this allows us to have a very detailed look at the biodistribution and determine the optimal imaging time points for this probe based on the organ that we want to image. So the macrophage binding probe is a relatively small molecular weight imaging agent. Here I have an example of a nanoparticle. Basically, this is a thermosensitive dendrimer that is labeled with a fluorescent dye, or in this case also with an 18-fluorine. This is a collaboration with a Chinese group in Nanjing, and they've used PET imaging, first of all, to look at the accumulation of this dendrimer in tumor tissue. So on the left, I show 18-fluorine PET images over the course of 8 hours, and we can see the accumulation of this dendrimer in the tumor occurring. In the middle, we see the accumulation of this probe as quantified from the PET images, and we can see that the accumulation is not at peak yet. We can still see that the signal is increasing. However, the 18-fluorine has a relatively short half-life, so we cannot image past the 8-hour time point. So even though the 18-fluorine PET imaging offers very sensitive quantification, there's a limited ability for longitudinal studies, and the resolution is relatively poor, as you can see. An alternative would be to employ optical imaging, which does allow for longitudinal studies, and we can see here that indeed this probe continues to be taken up over the course of 3 days. However, with optical imaging, we suffer from a very poor resolution, especially at depth, so that's kind of a limitation. Using the same dendrimer, but now employing MSOT imaging, we can also longitudinally track the accumulation of this probe. And we can see here over the course of 2 days that indeed this probe continues to be taken up in the tumor. Not only can we see this and quantify this, we can do this in 3 dimensions, as I show on the right with the 3-dimensional maximum intensity projections at the 24-hour time points. We can look at the different orthogonal views, and we can see the area that is being positive for probe uptake in 3 dimensions. As an additional advantage for MSOT imaging in this project, we can co-localize the nanoparticle distribution with functional imaging. So here in the red and blue, we show oxy-deoxy maps of the tumor. So we can see in blue areas of relative hypoxia, and in red areas that are very well perfused. When we co-localize this with the dendrimer uptake, we can see that the dendrimer is mostly localized in areas of relative hypoxia. This project was also published in the Journal of the American Chemical Society just a few weeks ago, so if you want to learn more about this, you can read it up in that paper. This next example is a theranostic approach with MSOT imaging, where we take photodynamic therapy agents, 5 different classes. This was a collaboration with a group in Singapore that was interested in studying these photodynamic therapy agents. And first of all, they used, shown here in this slide, a phantom approach to prioritize which agents they would use in vivo first. So they wanted to do MSOT imaging to detect localization, after which they could start the treatment. So just by doing this relatively quick phantom analysis, we can see that the zinc phthalocyanine dye, zinc PC, actually has the best conversion efficiency of the light into the photoacoustic signal. So that PDT agent was now prioritized for in vivo studies, and this is what we show here. We did a full in vivo biodistribution analysis. On the left, we can see an oxy-deoxy image where we can see the spinal cord on the top. The kidneys are labeled with a K. The liver is indicated there. You can see the intestines and the spleen. And more importantly, on the right flank of this mouse, we can see a tumor labeled with T. In the middle, I show a temporal color-coded image of the zinc PC signal over time, and we can see how this probe is distributing over time. We can quantify these signals shown on the right, and we get a whole comprehensive biodistribution analysis of the zinc PC signal. When we focus on the tumor, we can now look at tumor-to-background ratios, and we can calculate out that the optimal tumor-to-background ratio occurs at 60 minutes post-injection. So this allows you for a very quick optimization of theranostic approach. So we can optimize and prioritize which agents to use, and we can also figure out what's the optimal treatment time point for these agents. So that was distribution and metabolism. Moving on to excretion, I first show you here an example of urinary excretion. In this case, we injected a dye that ultimately ends up in the urine of these mice, and we have 3 snapshots here over different time points of this mouse. The mouse was in the system for about 2 hours, and we can monitor how over time the probe is being taken up in the bladder. On the right bottom there, we see a video of this process. But more importantly, we can also draw a region of interest, as shown here in this image, and we can quantify this urinary excretion profile. We can then use this urinary excretion profiles to actually deduce pharmacokinetic parameters from this urinary excretion data. Now, looking at the kidney rather than the bladder, we can also have a more detailed look at the renal clearance process. So in this case, we had a conjugated polymer that is small enough to be cleared by the kidneys. And when we do this MSOT imaging, as I said before, we can actually distinguish the renal cortex from the renal pelvis. This allows us to have a very detailed look at the clearance process, because after we inject these conjugated polymers, we first see them circulate. So you can see here, we see them circulate in the renal cortex, but after a short period of time, the probe starts to end up in the renal pelvis, after which it would move towards the urine. So we can see this process over time. We have a time-lapse video of that as well, where we see the probe circulate first, then ends up in the renal pelvis and also in the spleen, as you can see here. We can now draw small regions of interest within areas of the kidney, and that's what I show here. So we have a region of interest number 1, which is located in the renal cortex, and then regions of interest number 2 and 3 that are in the renal pelvis. And we can get this kinetic information, and we can see that the Tmax is very different for these different regions of interest. So in the renal cortex, we have a peak concentration already at about 3.5 minutes post-injection, whereas the renal pelvis, it takes 10 to 20 minutes to achieve the peak concentrations. So a very similar type of experiment is shown here with a different dye that is exclusively renally excreted. And again, we can see this very similar behavior where the probe is first circulating through the renal cortex, after which it ends up in the renal pelvis. The reference cryofluorescence is shown on the left bottom here. So we can see first the circulating dye, after which it ends up in the renal pelvis before it gets excreted in the urine. We can now draw different regions of interest in the cortex in orange or in the renal pelvis in black, and we can actually see and observe this lag time. So we can see that the concentrations peak early on in the renal cortex, and as this clearance occurs, we also see the probe ending up in the renal pelvis. So we can quantify this lag time, and this would be most likely would be impacted by toxicants. And this is an experiment that one of our customers in Liverpool has actually done. So this is what I show here. We have a control mouse on the top and an adriamycin-treated mouse on the bottom. So adriamycin actually induces a renal toxicity. So now if we use the same dye that I was showing in the previous slide, we can see that this process that I was describing is actually delayed. So in the control mouse, the dye ends up in the renal pelvis very early on. So we can see here, whereas in this adriamycin-treated mouse, the renal pelvis signal shows up much, much later. We can quantify this lag time, which is shown on the right for different treated mice. And we can see a significant increase in the lag time between the maximum time in the cortex and the maximum time in the pelvis. So now we have a non-invasive method to assess renal toxicity without having to sacrifice mice and have a look at the kidneys themselves. Similar experiments would be possible for the liver to assess liver toxicity. This slide shows a potential application. So we didn't induce toxicity in this case, but we show how we can use the very well characterized clearance of ICG. It's very well described that this ICG dye gets taken up in hepatocytes first, after which it gets taken up in the gallbladder. So we can image this by MSOT, as I show here. We can see the gallbladder. We can draw an ROI over the gallbladder, and we can also see the liver. We can now see how fast the ICG signal peaks in those different organs, and we would imagine that if there was a hepatic agent administered to the mouse, that this process would be delayed, just like the renal clearance process would be delayed in the previous case. Last topic of today's presentation is dynamic contrast enhanced MSOT imaging. So basically, this means that we employ the kinetic modeling that I was showing before on a per pixel basis. So if you look at the example of the renal clearance again, which I show here, is we can have these different concentration time profiles shown on the left, and we can do this for every pixel in the image. We can then create parametric maps, which is basically a visualization of a temporal imaging data set. So we show here 3 different parametric maps of the maximum concentration achieved on the left, the time at which the maximum concentration is achieved in the middle, and the elimination half-life on the right. So if you look at the middle images, it becomes very apparent that the maximum concentration of this conjugated polymer in the renal pelvis occur much, much later compared to the renal cortex. So now we have a visualization of this temporal data set, and this can be very powerful. Another example is shown here, where we have a tumor perfusion data set. So here we injected liposomal ICG, and we observed the tumor compartment. The red circles would be the ICG signal over time, and the blue line is the pharmacokinetic fit to the PK model shown in the cartoon. So we can calculate how fast the ICG is coming in and how fast it's leaving. We can do this on a per pixel basis and create those parametric images that I show on the right. So on the left, we see a parametric image of the maximum concentration. So we can see that the maximum concentrations are actually achieved in the periphery of the tumor. When we compare this to the Tmax, which is the time at which the maximum concentration is achieved, we can see that in the core of this tumor, it takes up to 15 minutes for the ICG to be delivered. So even though the concentrations are not that high, we can see that ICG is being delivered, it just takes longer. When we compare this perfusion information with hypoxia information here in blue and red, so in blue we see areas of relative hypoxia in this tumor, so it would make sense that the ICG would take longer to reach those areas of the tumor. So basically by combining this oxy-deoxy imaging with perfusion imaging by DCE MSOT, we actually know, yes, this tumor is poorly perfused, but ICG is still being delivered to the center of this tumor. It just takes longer. So to conclude, I showed today that multispectral optoacoustic tomography can provide anatomical, functional, and molecular information. It does this in real time and a very high spatial resolution. We achieved resolution of 150 micrometers in the cross-sectional images, also at depth. Today, specifically, I showed how we can use MSOT imaging to visualize and quantify various processes related to pharmacokinetics and biodistribution. We looked at how we can deduce plasma concentration time curves from MSOT imaging. We looked at whole body biodistribution at a very high spatial and temporal resolution. And we did longitudinal studies and showed the accumulation of different dyes and particles over time. We can look at the absorption and distribution and excretion of various compounds, and we can use that type of information, especially the kinetic information, to assess the toxicity. And lastly, we can create barometric images by employing DCE MSOTs, which can give a very powerful and unique look at how certain kinetic processes are occurring, which gives a new level of information on the, for example, the tumor status. Most of what I discussed today can also be read in these mostly recently published papers. If you would like to receive a reprint of any of them, please let us know. We can share these papers with you if you want to read more. With that, I would like to conclude this presentation and open up for any questions that you may have. Thank you very much.
Thanks, thanks very much, Wouter. We have a few questions here that we're going to try to answer in the coming minutes. Maybe just start with some general MSOT questions. First one here is, does photobleaching occur during the imaging?
Yeah, that's an important question and an important experiment to do, especially for these kinetic types of approaches. So the dyes that I showed here, we haven't observed photobleaching. Basically what we do is we take phantoms and place a certain amount of dye in these phantoms and illuminate the phantom at the peak absorption wavelength for long periods of time. So basically we can do an in vitro experiment and figure out if the laser illumination bleaches the compound or not. This can occur, so it's an important experiment to perform before going in vivo. But for the examples that I showed today with Alexa Fluor and ICG, we did not observe this photobleaching for the periods of time that we were imaging.
Okay, another question. How do you determine actual probe concentration from the photoacoustic signal?
Yeah, so I showed a few examples in the beginning on the pharmacokinetic profiles. So basically what I did there is we get the MSOT information, we get the MSOT units, which are typically arbitrary units. However, at the end of the experiment, I was collecting the blood of these animals and made standard curves with the injected probe. So this way you can make standard curves of the probe in blood and convert your MSOT units to actual absolute concentrations. So this is something that can be done, but would require some additional effort by calibrating your MSOT units to absolute concentrations.
Question, is the PK under anesthesia?
Yes, so the animals for MSOT imaging need to be anesthetized by isoflurane or injectable anesthetic, but yes, the animal needs to be anesthetized for the imaging. So yes, all these experiments were done with the animal under anesthesia. It is still being heated actively, so it is heated. We can also monitor the heart rate, the respiratory rate, etc., if you would want to, but the animal does need to be asleep for this type of imaging.
Maybe another preparation question. Do you have to shave the animal?
Yes, just like in optical imaging techniques, we also have to shave the animal, but for slightly different reasons. So first of all, we need to deliver the laser light, so we illuminate the animal from all around the animal, and to achieve efficient light delivery, we need to remove the hair. More importantly, though, we detect ultrasonic signals, and ultrasonic signals don't cope very well with air bubbles, so and fur is exceptionally good in capturing air. So we do need to remove all the hair from the mouse if you want to do this type of imaging.
Let me just see here. Question regarding imaging the lungs. Can you measure excretion through the lungs?
Yeah, that goes along with my previous comment. So any ultrasonic detection method does not cope very well with air, because ultrasound signals don't travel through air very well. So the lungs are a problematic area for MSOT imaging. So the answer would be no. The lung area is an area that we cannot image very accurately.
Can you image larger animals, so rats, maybe even bigger, pigs, monkeys?
So rats, yes, up to with the preclinical system, up to a certain limit. So we can image rats up to about 200 grams in size. If you want to go larger than that, I would recommend to use our experimental imaging platform, which has handheld ultrasound probes. So with these probes, you can image any size animal, including humans. But yeah, so if you wanted to image pigs or sheep or monkeys, you would need to go to the handheld approach and not with the Envision system that I described today, but the other system that we are developing and have available.
Okay, maybe some PK questions. Can you determine glomerular filtration rates, or GFR by MSOT imaging?
Yeah, in principle, yes. So there's a lot of literature out there where people, for example, labeled inulin with fluorescent dyes and use this as a measure of glomerular filtration rate. So these types of techniques could also be employed for MSOT imaging. So if you wanted to distinguish different types of excretion by the kidneys, we would need to develop different molecular imaging agents, which is an area of interest for us, so that we can distinguish the different types of excretion by using different types of molecular imaging agents. So the answer is yes, this can be done.
And can you assess cardiac toxicity?
Yes, I think you can. We would need to employ some motion correction in that case. Of course, the heart is moving at a very high rate, but we can also image at a very high rate and actually do post-imaging motion correction. And if we employ this, I would imagine that you can also image the cardiac toxicity. So we have a few papers out that look at some cardiac functionality. It looks at ventricular volumes, for example, or we can use molecular imaging agents to visualize certain processes, for example, apoptosis in the heart area or macrophage accumulation. Those types of experiments are possible, so I would think that we can also assess cardiotoxicity.
And maybe last question, if I already work with several fluorescent probes in the lab, can I use those also for optoacoustics?
Yes, as long as they absorb, so their excitation spectrum is in between 680 and 980 nanometers. So basically every probe that absorbs or over 680 nanometers can also be used in photoacoustics. So fluorescent agents are also possible. For example, ICG is a fluorescent agent, and this can also be extremely good MSOT contrast agent.
Great. Thank you, Wouter, very much for the presentation and the questions. Thanks to all of you for joining us today. We will follow up on some further questions by email, just because we can't answer all of them right now. If you have any further questions that you would like to have answers, please feel free to contact us. anytime, and we'll be happy to answer by email, by phone, and get your questions answered. Yeah, I wish you all a great day, and looking forward to maybe seeing you in the next webinar.
Thank you, everybody.